Hi, Josh. How are you?
I'm doing good, Stephanie. How are you today?
I'm good. I, I've been selling Medicare insurance for a very long time, about 20 years. And during that time, I'm kind of in this unique position where I get to see people throughout their entire retirement, right? I see them when they're healthy, they're traveling, they're hanging out with the grandkids, all that kind of stuff. And then as the years go by, I see people as they sort of, you age and you get a little bit slower and it takes a little longer to make those hard decisions, and then they start talking about more doctor's appointments and more health issues and that kind of thing. You know, I I'm going through this in my own life, right? I had recently went to a funeral, and the kids were talking about their mom, and she had had COPD, and she was doing really well for a while, and then it got worse, and she spent the last 3 months of her life in the hospital. And the daughter said to me at some point, we knew that she was not going to come home, but we didn't know what to do. We couldn't take care of her at home. She had all these machines hooked up to her, and we couldn't hire a home health care nurse, and we didn't know what to do. And so she spent her last few months in the hospital. And it was right after that funeral that I heard you speak on the panel. And I know, we're both part of that Senior Learning Institute. So we do educational seminars for seniors. And what you said that stuck out to me was that people don't know hospice is available. And a lot of times doctors don't even tell them that that's an option. And so I wanted you to get the information, to talk to us, tell my clients, tell people that it is an option and it's not what you think. It's not just the last few days and end of life and it's awful, but this is actually could be a good thing for people. With that, kind of when people get to you, is it the kids that are calling? Is it the person themselves? Like, how does that conversation go? What I would guess that there's a lot of hesitation. I don't really know if I want to be in hospice. Like what a lot
Mm.
of unknown, but what does that look like?
So it looks in a variety of ways. So to your point, um, this is not something a lot of people know about because for most of us, we're really uncomfortable talking about our mortality. We're uncomfortable talking about death and dying, especially for ourselves or the people that we love. So for many of us, when we struggle to talk about things that we're uncomfortable to talk about, we oftentimes just don't talk about it. So then what ends up happening is someone at the end of a long illness like COPD ends up in the hospital and people are no longer able to make decisions for themselves or they rely on their family to kind of help drive those decisions with them alongside them. And there tends to be a lot of not necessarily misinformation, but a lack of information. So quite oftentimes when people end up coming to us in hospice, it's after multiple hospitalizations. It's after some hard conversations about realistically what's going on for that individual or with their family. But we also see some people who literally call their doctor up themselves and say, hey, I heard about hospice. And I think that's probably where I'm at or getting close to. Who can I talk to about it? Um, and quite often, one of the things that gives us the most joy here with my team in St. Louis is we had just this happen this past week where a family member calls us of someone who needs hospice and said, you took care of my friend. You took care of my other loved one several years ago, and now it's time for me or it's time for another loved one to get the help, and I'm reaching out. How can we get this started? And so the beautiful thing about hospice and the way it differs from traditional healthcare in the United States is that traditional healthcare is very much disease centered. And this isn't a negative, but this is just for the sake of helping us to get the appropriate resources to the appropriate type of patient. So quite often when someone goes to the hospital, like with a severe COPD exacerbation, they're a lung patient. They kind of get put on a floor or in a department where people are used to taking care of those types of individuals, or a heart patient, or a cancer patient, or a neuro patient, right? So we kind of put patients in these buckets for the sake of getting them the appropriate help. The way that differs from hospice is definitely more of a human or person-centered healthcare model. So the definition of hospice and palliative care is actually human-centered care designed to treat suffering in all of its forms. So we know that sometimes when patients present to a hospital, what they're there to get focused on is their symptoms, right? Their physical ailments. And hospice tries to reintroduce the psychosocial, spiritual, emotional, and other components that make up the whole person. So when we try to help and alleviate those things, people come to us in a number of ways. And sometimes their trauma and their pain, their suffering isn't just manifesting itself with things like pain, shortness of breath, or nausea, but sometimes there's that emotional distraught too of someone going, I'm not ready to die, or I'm not ready for my loved one to die. And there's that emotional component too that we're actively working to help support and treat also.
So how do you do that? Is like, what is the process? It's not just someone with the patient around the clock. Like, you're helping the whole family. You're helping them, their family, with the healthcare and other things, right? What does that look like?
Right. So the hospice team is actually what's known as an interdisciplinary team. So the way that may also be different from a traditional healthcare setting is quite often if you go to a hospital, they're taking a multidisciplinary approach, meaning you might have physicians with different specialties who come and provide their support and provide their insight, but they may never really confer together. So you might have doctors, you have a pulmonologist who comes to see, and he's focusing on what's best for the lungs, while then the cardiologist comes right behind him. He might change medications because he's doing what's best for the heart. Now, they're both taking a big picture approach, but they're not necessarily sitting in the same room at the same time and having those conversations. The hospice team is about having all these specialists and these different team members coming together in the same room quite often to talk about taking care of the whole person. So the hospice team consists of the hospice physician, a hospice nurse, a nurse's aide, social worker, a chaplain or spiritual counselor, volunteers, and all of the operational team members that help kind of drive this forward. And so what that may look like for some patients is the nurse comes in and they're really focused on controlling symptoms like shortness of breath and pain. And while they're there and they're having conversations with a patient or family, they also hear that, family are really struggling with making funeral arrangements, and that, hey, dad was a veteran and he really would like to be honored for that. And, they were looking at arrangements to go to Jefferson Barracks, for instance. Well, then we know how to get our social worker and our chaplain involved to help start supporting the family from a psychosocial component and taking the burden of those decisions away from them, or helping be their guide, right? And helping to ensure that we do our part in taking what we can off of them so they can just focus on being with their loved one in that moment, and focusing on comfort and quality time. Quite often people think hospice is about just dying well, but it's also about living well with the time you have left. And that is helping to be a guide for patients, families, loved ones, and the other healthcare professionals involved in that individual's care to ensure that they understand what options are made available to them, and they can also live a full, complete life with the time they have left with peace, comfort, and dignity.
Yeah, I love that because we're all going to die at some point, and you can figure it out. You can do it in the hospital. You can figure it out on your own. But if you have the time, if you have this, if you know something's happening ahead of time, you guys provide comfort, the peace of mind, that support, just not only to the patient, but to the family. And I think that's important. And I think not enough people get that.
Yeah, I agree. And, something to consider as well when we talk about hospice is this is very different than planning for other major moments in our lives, right? High school graduation, marriage, having children, buying that house, these major life events that we all talk about, we all plan for. But how often do we get together with our friends and start talking about, hey, what are your end of life plans? What are your goals, right? We don't talk about it. And so, an interesting example would be, I have 3 children. When my wife and I had our first child, there was a lot of unknowns. We were excited. We went to classes. We were trained. We asked a lot of good questions. We read books. We watched videos. And we felt very prepared. But the preparation did not necessarily replace firsthand experience. So then by the time we had our second child, we had more experience. And then by the time we had our third child, and I remember we arrived at the hospital, my wife was all excited because she had a folder. She had a plan. She knew exactly what she wanted and how she wanted it. What her conversations were with her doctors were very different because she's had a big experience of having 2 prior children. She knew what kind of music she wanted to have playing, right? So when we showed up into the labor and delivery room, my wife's doctor said, all right, Anna, do you have your plan right? She goes, yep. And she pulls out a folder and just hands it to her. She says, here's my whole plan. We don't have that same experience with death because we only die once. So, it really then comes down to our proactive ability, one, to plan, ask good questions, and understand what options are available to us, but also by reinstituting the amount of support that goes into helping someone at the end of their life, and realizing it shouldn't just be on the healthcare professionals and on the hospital systems, but it should be on our families and our communities as well. Our hospital systems, our medical system is a beautiful thing. I can walk halfway decent after a major accident I had years ago because our healthcare system kind of helped put me back together. Our hospitals are designed to treat acute trauma and to help people with curable illnesses. It's not a place that's designed to help people at the end of life, even though they can be of assistance. So by having open and honest conversations like this now about what people want and asking what we would traditionally consider to be tough questions, it helps us better prepare to support each other and ensure that, to your point, if we're all going to die one day, it's on our terms and we still have some control over what that looks like and how we die.
So, do you feel like that's the biggest hang up? The reason that people don't pursue hospice or know anything about it is because they just don't want to talk about it, don't want to look at it? Or do you think that there are other things that go into it?
I think it's a multifaceted answer, right? So I think one is that our healthcare system, we kind of took death and dying out of the home years ago. As health and medicine got better, and we've been able to put people back together and innovations and procedures. And I mean, look at like organ transplantation, right? Or major operations for like hip replacements, things like that. We've done miracles, things that 100 years ago wouldn't have even been possible. So we kind of now keep putting death off as almost it's like it's a treatable disease, like having diabetes or heart failure. And you can be the healthiest person in the world, in the entire world, but eventually at 105, 110, 115 years old, your body is going to get tired and it's going to start preparing itself to die. Our bodies are amazing, amazing works of creation. So in that instance, we've, as a society, have done a poor job of keeping death involved in the family conversation as part of the circle of life. I hate to make it that simple and use like a Lion King reference, but that's really what it's about. And if we have so much intentionality about having children or about having a career or buying a home, we should have that same intentionality when it comes to what our end of life experiences should be. The other part of that as well is, we've asked so much of our medical system and of our doctors, where now for some physicians and providers in some hospitals, death is almost considered a sign of failure for a patient. A patient can have end-stage COPD and heart failure and diabetes and have all these chronic comorbidities, but we're still upset and angry at times that the hospital couldn't do more. Well, again, that comes back to us having our own understanding of our mortality as human beings. There's a great saying, and that is, coming to terms with one's own mortality is a process, not an epiphany. Well, if it truly is a process and it takes time to kind of come to terms with our mortality and to understand what we want out of life, but also out of death, we have to make space for it. We have to have conversations like you and I are having today, but more importantly with our loved ones. And so that way they know that when they're put into a position where maybe, God forbid, you're having to make decisions for your loved one because they can no longer make those decisions for themselves, it's not about, oh, everyone's looking at me and am I going to do the right thing or the wrong thing? It's about, hey, we've had these conversations. I know exactly what my loved one would have wanted, and now I'm going to honor them by following their wishes.
Yeah, I would think that it's very hard for the family, sometimes harder for the family than the individual, just because you don't want to make a mistake. You don't want to make that decision that they wouldn't want. Um, so I like that you guys help the whole family as well.
Yeah, absolutely. And I think, the last part, I think, of the hospice misunderstanding is when is hospice appropriate medically? Because it's a specialty just like cardiology is a specialty or neurology is a specialty. It has its own designated place. So if you aren't familiar with it or you don't seek out the help of the professionals who specialize in end-of-life care, you may unintentionally get some misinformation. So what I often tell people is, when they're learning about hospice and I explain that this is a benefit that's designed and people qualify for it as soon as their physician believes that a person has a prognosis or life expectancy of 6 months or less. People oftentimes, I've never heard of someone being on hospice more than 2 weeks, right? Because that's their experience. And that's quite often a failure of our own pre-planning, our own conversations, of our own healthcare system, in the sense that we think hospice is only designed for, the very end of life, right? When we're on death's doorstep. One of my favorite patients that we ever took care of, he was diagnosed with a terminal condition pretty suddenly. He was an elderly gentleman, and he knew his situation, and he was very open and honest about where he was at, and that he was very realistic about what the next steps looked like for him. He wasn't a candidate for surgery. He needed to be on hospice, and he was ready and accepting of that help of the hospice team. So we made an appointment to go out and see him the next day at 2 p.m. And my nurse arrived at his house a few minutes early to kind of get there and start visiting with him and start the process of admitting him onto hospice services through Medicare. And she went to the door and rang the doorbell and knocked, and no one answered. So she goes, well, I'm a little early. I'll give it a little bit of time. So she gave it a few more minutes and went back again. And so no one answered. So she called him and said, hey, this is the nurse from hospice. I'm here to visit with you today, but maybe I'm at the wrong house. There's no one answering the door. And he goes, I'm so sorry. I'm just down the road. I'm out riding my bike. That doesn't really sound like a hospice patient, a patient who needs to be on hospice. He's out riding his bike, but the reason why he was doing it is because he still could. It's something he enjoyed and loved to do, and he wanted to keep doing it as long as he could do it safely, and it brought him that joy. So you'd think, well, is that guy really hospice eligible? Is he appropriate? Does he qualify for hospice? Well, not only did he qualify for hospice, but he actually expired less than 3 months later, passed away on services with the support of the hospice team. So, end of life can look very different. And I think it's important for us that when we say end of life experience, we're not talking about the final moments or days. We're talking about weeks and months of the lead up to us taking our last breath. And it's important that we use that frame of our conversation to understand what we want the last 6 to 12 months of our life to look like, not the last 6 to 12 hours or days.
Yeah. I know this might sound harsh, but I wonder if sometimes people don't do it because they think it costs also. They think it's too expensive or something like that. But this is one of the few things that Medicare actually covers 100%, no matter what kind of supplement or advantage plan you have, right?
Yeah. So, you're so right. And it's unfortunate that in today's day and age, quite often the cost of healthcare can be one of the reasons why patients don't pursue treatment. Before I found my way to hospice, I worked over 12 years in healthcare, with the majority of my time being in cardiopulmonary and helping respiratory patients like, your friend's relative who had COPD. And it's a sad thing to hear that, hey, my doctor prescribed me medication and I went to go get it filled and I couldn't afford the copay. So I just said no thanks and walked away. Right. And it's sad that sometimes people are having to choose between taking a heart pill or a blood pressure pill or a diabetes medication and those sorts of things. Hospice is one of the few things that Medicare does pay at 100%. And it doesn't just pay for all the services of the hospice team that I mentioned before, but it also pays for 100% of all the medications and all of the medical equipment that's needed to provide that care safely to that individual wherever they go home, whether that's in their private residence or in a long-term care facility. And some patients actually do receive hospice care inside of a hospital as well. So it's important for individuals to know that if they're ever concerned about, well, what does the cost look like? The cost is everything related to that person's terminal condition in order to provide care for them with the goal of alleviating pain and suffering, keeping them comfortable, and focusing on dignity and respect at end of life. That's what's covered at 100%. So quite often, the other part of that is the perception of hospice. That, okay, if I stop chemotherapy or I stop going to the hospital, that I'm giving up. And my family's going to think I'm giving up. And that's just not the case. It's not the fact that people who decide to go on hospice are giving up hope. It's that they decided to redefine hope. So for instance, my grandfather passed away on hospice 9 years ago last month, after a cancer diagnosis and him going through treatment for 11 months following his diagnosis. And, when he was originally diagnosed with cancer, his hope was for a cure, to have his body rid of this disease and to be able to keep living a long, healthy life. Well, when it became evident that a cure was no longer an option, it wasn't that he was giving hope on a cure, because miracles do happen, but he decided to redefine hope. He said, okay, hope used to mean for me a cure and being rid of the disease. Now hope means for me being comfortable, being at peace, not being in any pain, not suffering, having my family taken care of, and knowing that everything's going to be okay. Because for most of us, when the time comes, and having conversations with patients who are on hospice all the time, what I quite often have found is that patients aren't actually afraid of being dead. What they fear is the process of dying, suffering, and then the pain and the sorrow of their loved ones after they're gone. And so all those things are helped and supported by open and honest conversations about end of life goals and what we want from this life, including our end of life plan.
So you really are helping just redefine that end of life journey, make it smoother, make it more comfortable. And then even when that patient is gone, when that person's gone, you still support the family with grief counseling and that sort of thing, right? Is that part of hospice
Yeah.
care?
Hospice care doesn't end when the patient who's on our services passes away. For over a year, we provide ongoing bereavement support and grief support for individuals. Here in St. Louis, my team at AccentCare also run a grief counseling group where they bring people in who want to come and be with others and share. Quite often, these individuals are also the ones that, after they've hit certain milestones and feel like they're at a good place, say, this has been such a positive thing for me, I'd like to give back. And quite often, many of our volunteers in hospice come and are family members or loved ones of people that we've cared for in the past, who saw what a blessing hospice can be. Again, with the understanding that if all death is certain, then the way we die is important. And if everyone dies and not everyone has a good death, well, what can we do to ensure that myself or my loved ones do have a good death? So, providing that extra care and support is important. I know when I've lost my loved ones, those, especially in the first year, those first big things like their birthday, Christmas without grandpa, or those sorts of things, they hit a little differently. And so knowing that you have people who are also reaching out to you and providing resources and just checking in can be a beautiful thing. So that way those individuals know that they're not alone, because we've all felt after the loss of a loved one, whether it was expected or unexpected, we've all felt the love and support of our group, our family system, our tribe, our network, right? Everyone shows up at the funeral. People are checking in a lot, but life goes on and those check-ins become more infrequent. And it's nice to know that there's the professional group of people who are there as well, who are continuing to provide that care and love and support on those key occasions as well.
I think the service you provide and is important, and I think talking about it is important too. So I'm glad that we could do this. If people want more information, or what's the best way to do that?
So there's a couple of different ways. One, you can go to AccentCare.com, which is the organization I work for, AccentCare, and you can find out more information about hospice. But there's a lot of really good nonprofit organizations as well. There's the National Hospice and Palliative Care Organization, or the NHPCO. I would encourage people to look up. And then here in St. Louis, we have the Gateway End of Life Coalition, a great nonprofit organization who are focused on not only demystifying death and dying and helping to educate individuals about the process and the resources that are available to them, but also advocating for what we're doing today, which is having open and honest conversations and completing an advanced care plan or advanced directives. One of the most important things we can do for our loved ones is giving them the gift of pre-planning, of not putting that burden of decision-making and choice on their shoulders, where now you might have a child of an individual who's being charged with making decisions, now in a disagreement with their sibling, right? And, well, I disagree with what you did there. And it's so unfortunate when in a time where someone's having their end of life experience, which should be a time for people coming together and remembrance and reflection and love, but it oftentimes can be tumultuous and be cause for division and strife within family and loved ones. So by pre-planning, by having an advanced directive, by talking with your physician and your loved ones about what you want your end of life experience to be, you remain in control while also taking that burden away from your family, and just allow them to have that gift of just following your plan and ensuring that you get the care at the end of your life in accordance with your wishes and what you want. It's like with my wife, when we had our third child and the music's playing in the background of what she wanted to be playing, we should be having the same conversations. We should be talking about what music we want playing when we're lying in bed in our final moments, or what we want said at our funeral, or how we want to be remembered. What does our legacy mean to us, and how do we want people to view it? Those are all things that I think are important that we may contemplate internally and have those conversations with ourselves, but not quite often externally enough. So just the more we look at those resources and then have a conversation is important. And if anyone's struggling with how to even just start the conversation with their family or loved ones, there's some great resources out there by an organization called the Conversation Project. And they can look them up as well online. And it just is a really good, open, and very plain English ways of starting a dialogue with your family and your loved ones and having these tough conversations through kind of guided conversations that allow us to get to what's important to us. And I think that if we were all to sit down and be honest about what we want at the end of life, we'd say, well, I want to be pain-free. I want to be at peace and comfortable. I want to be surrounded by my loved ones. And I want to be, in a place that's important to me, like my home, or, in a beautiful place. And I think for so many of us, we might take that for granted because we actually have that on a very regular basis. But those are the things that we often cling to the most in an end-of-life situation. So by just being honest about that to ourselves first and foremost, and giving ourselves grace with these contemplations and these decisions, but then opening up with our family, the more we normalize the conversation, make it routine, the better we'll be able to have those conversations, the better we'll be able to support each other in those situations, and the better our end-of-life experiences will be for our community.
So have the conversations and plan. So one of the things that I think would be really hard for people is when they actually have to make that decision and sign that piece of paper that says, I no longer want medical treatment. I know this is the end, and I don't want to be doing the chemo and all the treatment anymore. Do you find that that's kind of a holdup for people?
Yeah, it definitely can be. I think, people come to that decision in very different ways. So sometimes it's through an open and honest conversation with their physician in an office and saying like, hey, I think we need to start talking about different goals of care, right? The goal of curative treatment versus comfort treatment or comfort care. Sometimes those conversations are happening over years. Someone might be diagnosed with a progressive disease like COPD, that the average person lives with it for 20 years. And sometimes it's someone who just all of a sudden something happened. They went to the doctor and found out they have end-stage cancer and they were feeling fine a week ago or whatever that looks like. So those conversations can be very different and very difficult depending on the individual. What ultimately determines someone's acceptance is how much time they've spent contemplating and planning for their end-of-life experience ahead of time, regardless of the situations that caused it to arise or brought them to the place where now they're considering electing the hospice benefit. So it's really important that for those individuals, they understand what options are available to them. For many people, to go on hospice, it is stopping a lot of curative treatment. Like if they are getting dialysis, it's stopping dialysis. If they're getting chemo, it might be stopping chemo. Now, there are some really new and exciting developments happening in end-of-life care where it allows some patients to receive hospice care while still receiving some curative treatment, but it's very goal-specific. It goes along with a very individualistic approach and based on what the insurance is reviewing and thinking. Because there are more studies that have found that if people are allowed to access their hospice benefits sooner, along with goals of care and have some access to some curative treatment, that individuals access hospice at a quicker rate. And hospice has been shown overwhelmingly to have a positive experience on patients and their end-of-life experience. But just as importantly, helps people and their loved ones feel that support as well, get them the additional resources they need, and allows people to be where they want to be at end of life, which for so many of us, if you were to ask, where do you want to be when you die? And I don't know if you've ever answered that question yourself, Stephanie, but for me, it's definitely not in a hospital bed at the hospital. Like, that's just not where I want to be. So if we can start with simple premises like that, like where do you want to be when you die? I think then we can really start having a good conversation about what we should be doing and what our next steps are. In our country, patients are kind of in the driver's seat. We get to kind of decide what we want. And I think that's important. And no place is that more evident than in hospice and end-of-life care. That human-centered care model is designed to put patients and their families at the center and say, what do you want this to look like? Someone might say, I'm really focusing on this. I don't want to be in pain, but I also don't want to be sedated either, right? I want to be alert for as long as I can be. And so we're going to have conversations about how do we achieve these goals meaningfully with the hospice team and the care team. So, just having those conversations is important, but how we arrive to it can be different for everyone. And, I think it's not an easy decision, but if anyone has any additional questions or doubts, just reaching out to a local hospice provider and having a honest conversation, a non-obligatory conversation about what the options look like and what kind of care could be provided and what that would look like for them is important, because at the end of the day, what sometimes happens is people don't have enough information. And then that's when we get the feedback that is so unfortunate from families after a loved one passes away saying, I didn't realize this is what hospice was, and I wish we would have done it sooner. And what we want to help people do is say, I know what this is. I've prepared for it. I'm ready for it. I'm so thankful that there's a team here to help me. And that's what we're trying to help people get to.